Welcome back. Continue to take a look at the heart and start off today with the heart valves. And so when we mentioned the anatomy of the heart itself, we talked about blood moving through the valves themselves. And these valves are going to make sure that our blood is moving in just a single direction through the entire system. So as it moves through the heart and then out into the blood vessels, we don't have any backflow of the blood themselves. The valves can be kind of talked about in a couple different ways, one of which is to talk about where their placement is. And so we have atrioventricular valves, or AV valves. We have two types of them. We have either a tricuspid valve or a bicuspid valve. The tricuspid valve goes between the right atrium and the right ventricle. The bicuspid valve, also known as the mitral valve, goes between the left atrium and the left ventricle. So this is going to prevent that backflow when the ventricles are contracting and they're creating lots of pressure inside of them. That's going to stop them from causing that pressure to build and build and build inside and not go back into the atria themselves. In order to help with that process, we have the valves kind of supported by the papillary muscles. And so they're supported by those papillary muscles where we have chordae tendineae attached to those papillary muscles. And as the chordae tendineae are attached to those muscles, as the muscles pull, they're going to hold those valves nice and tightly closed. Our other two valves, the aortic valve and the semilunar and the pulmonary valve, are both what we call semilunar valves. And so they each have kind of a half moon shape to the cusps themselves. Hence the name semilunar for them. These ones don't require any extra components on them, so they don't have any extra muscles on them or anything like that, because they don't require as much prevention of high pressure backflow. But once the blood has ejected from the ventricles themselves, this is going to prevent it from coming back from the aorta or from the pulmonary trunk, back from either the pulmonary circuit or that of the systemic circuit. So we'll take a little bit closer look at each of the valves themselves. And so as we come through the right side of the heart, blood passes through the tricuspid valve. This one, as the name kind of implies, has three cusps to it. Attached to each one of those cusps, we have chordae tendineae. And those chordae tendineae essentially originate from our papillary muscles. Those papillary muscles are going to contract at the same time as the ventricular walls contract. So they're going to hold those valves nice and tightly closed. The pulmonary valves, or the pulmonary semilunar valves, also have three cusps to them. And so they have three different cusps to them. So they're going to have a three portion to that valve itself. The valves themselves are very, very thin. They're almost paper thin in terms of their overall thickness, but they do a great job at holding that blood back from where they're supposed to be. The pulmonary valve goes in between the right ventricle and the pulmonary trunk. So after blood has gone out into the pulmonary trunk, it can't flow backwards into the ventricle. On the left side, blood returning from the lungs comes through the mitral or bicuspid valve, same valve. Just like on the other side, these valves have chordae tendineae attached to papillary muscles. And again, they're going to be active during ventricular contraction to keep the blood from going back into the atria themselves. We don't want to have any backflow there. Next up, we have the aortic valve, and similar to that of the pulmonary valve, this is a semilunar valve again, and it also has three cusps to it. The valve itself, again, is going to keep the blood in the aorta and not allow it to move back into the left ventricle. So here we have a look at the heart from above, and here we can see those cusps of our semilunar valves. And so the pulmonary valve there and the aortic valve here, we have those three cusps there. On our AV valves, the tricuspid valve has 1, 2, 3 cusps to it, but the bicuspid valve only has 1 and 2 to them. Hence their different names on there. We're looking at it from above, so we can't see the chordae tendineae and the papillary muscles for those AV valves just yet. If we look inside the ventricles and we look at those valves, we can see here on a cadaveric heart that we have those papillary muscles, and then we have the chordae tendineae there as well. And so here, a nice image here with the chordae tendineae and then a papillary muscle looking on the inside there. And this is where, in a sense, kind of the idea of heartstrings comes from, is that you literally do, in a sense, have strings inside your heart. They just happen to be the chordae tendineae. Their job is to restrict backflow of blood. And so when the ventricles contract, we're going to get contraction of the papillary muscles. Those are going to hold those cusps of either the bicuspid or tricuspid valves nice and tight, so that as the blood is trying to push back into these valves, they're not able to kind of flip open. So they're not going to move backwards at all. They're held nice and tight. They're going to be holding that blood back under a tremendous amount of pressure. But for the semilunar valves, the pressure out here in the pulmonary trunk and the aorta is always declining. So that blood, once we get out there, if we're in the aorta, our blood pressure may start at 120 millimeters of mercury as far as the pressure goes, but it's going to be constantly declining. And so as that blood flows away from the ascending aorta and out into all the different branches, that pressure inside there continues to fall. And the same thing is happening in the pulmonary trunk as well, which means that the blood, as it's going away, the pressure decreases, and there's nothing really trying to force the blood back this way like we had for the ventricles. And so we don't need the reinforcements, in a sense, of chordae tendineae and papillary muscles on those. The valves, though, can be susceptible to damage. And so sometimes that damage is from infection. Sometimes it's from autoimmune disorders. So we can have things like our rheumatic fever. We can have things like lupus that can damage those valves over time. And if those damaged valves are kept inside the body, there's the potential for blood to leak past the valve. And so as those ventricles contract, we're going to get movement of blood past that valve, and we're going to get what we call a murmur. And so we'll be able to hear a murmur in a person's heartbeat as we're listening to their chest itself. And so the replacement then is either a synthetic valve or a porcine valve. And so the porcine valve is a pig valve. So it is living tissue that is there, and that's implanted into the body and comes from pigs and has the ability to keep on living. The mechanical valve or the synthetic valve here is just that. It's metal and mesh and things like that with it. Comes in different varieties for that. And these are just simply 100% mechanical in nature. And so they're just going to simply hold the blood back based upon pressure variances in the body itself. That's there. And so those have their ability to replace those valves as needed. And here we have essentially the process of implanting a valve that happens within the heart itself. And so it can be done through a catheter. And so there are catheter procedures that can be done. Comes in just like a regular catheter, and they put the new valve in there, sew it into place, and as it sits inside there, it then stays there. Most of the time, though, this is an open heart procedure, and so they're going to open up the valve. In this case, it's an aortic valve. They're going to cut the old one out, and they're going to replace in the new one into the vessel itself. Another new procedure is available as well, which makes it very minimally invasive that is out there as well. And this is what's called the mitral clip. And so the mitral clip is able to essentially hold those natural valves closed, the ones that the person already has, and doesn't have the same invasiveness in terms of the procedure itself that's there. And so here we have an x-ray of a implanted valve. And so the valve has been put in there. It is now working. It happens to be one of the ball type valves. And so the ball sits inside there and catches inside the cage as pressure changes. We can also see evidence here of the procedure that this was an open heart surgery. And so we have metal ligatures here that are holding the sternum back together after it was cut open for the open heart procedure itself. This is the mitral clip procedure. And so you can see that they come in with a catheter again, and it's going to place a small little clip, almost like a paper clip in a sense. Here we can see it on the x-ray, those clips that are there. And those clips are going to basically just hold the valve closed a little bit and limit the amount of movement that it can do. And that's going to stop the blood from regurgitating quite so much. This person also happens to have a pacemaker as well. Here we have and you may be able to click on that link that is there. We have the link to the actual procedure itself for the mitral clip. You can go to that at your leisure and view how that actually occurs as well. So when we look at the heart and we look at the actual muscle walls of the heart itself, the muscle is slightly different from that of skeletal muscle in that it has kind of quadrangular types of cells. They branch a lot. They're connected together, remember, by gap junctions that help to hold them together. They don't really have an origin and insertion per se. So the muscle itself doesn't have something to pull on, so to speak. And so it's going to have all of the connective tissue that is in the heart in order to do so. And so the endomysium and the epimysium are going to serve as those insertions and origins for the muscle cells themselves. Those intercalated discs, the special connections between the cells, this is going to allow for the passage of ions. This is going to be one of the ways that we continue the contraction of the heart electrically within the heart itself as well. Remember that we need ions in order to have muscle contraction. And so our sodium ions, our calcium ions come into play when it comes to the contraction of the heart. And one of the ways that we're going to get it to move from one cell to the next is through those intercalated discs that we have. And so the heart itself essentially functions as a big, huge unit when it contracts. And so it's going to have this kind of flowing kind of a contraction over the heart itself, moving from the apex back up to the base when it comes to the ventricles. And here we can see just some microscopic views of the heart itself. And so here we have our intercalated discs. On microscope, they show up as dark purple lines that are there, almost look like kind of darker striations. And in those intercalated discs, we have our gap junctions. And so those gap junctions are going to allow us to move ions from one cell to the next. That's going to allow us to have that contraction of the muscle kind of spread across the muscle itself. When cardiac muscle does contract, it does have the ability to contract all on its own. And so it does have that ability to contract without any kind of nervous input. And so it is stimulated by the nervous system, but it's also self-excitable. And so the cells within can generate their own contraction as well. When it contracts, it's essentially contracting as a unit, but it's going to have kind of a delayed long contraction of that unit itself, again kind of moving from the atria down towards the ventricles, and then the ventricles are going to contract again from the apex back up towards the base of the heart itself. Unlike muscle, where we can have a refractory period of just a few milliseconds, the cardiac muscle has a refractory period that is upwards of 250 milliseconds just for the absolute refractory period. And so we're going to have kind of a long, prolonged kind of a contraction for the heart muscle itself. That's there. Otherwise, the whole process itself is pretty much like skeletal muscle. And so we're going to have all of the same proteins that are involved in the contraction process. We have all of the similar components available in terms of the movement of ions and things. All of that is happening within the muscle in a very similar way to that of skeletal muscle. So I mentioned that the heart is autorhythmic in that it can generate its own action potentials. And so it does this because it has specialized cells inside the heart. And so these are located in specific areas within the heart itself, and they can generate action potentials all on their own. Those cells themselves do so because, in a sense, they're kind of unstable. And so they have an unstable resting potential, which means that it doesn't take a whole lot to get them to fire off an action potential. It takes very little stimulation for that to occur. And that stimulation can simply come from ion concentrations. And so because cardiac muscle has less of a sarcoplasmic reticulum than that of, say, skeletal muscle, calcium is not stored so much, and so calcium influx into the cell is going to increase our action potential. So it's going to kind of, if we're looking at the resting membrane potential, it's the influx of calcium is going to increase that membrane potential up towards threshold. And that movement in of calcium is occurring oftentimes primarily at those gap junctions from one cell to the next. So it's the calcium permeability that changes. And as that membrane potential changes, as calcium starts to come into the cell more and more and more, we go from our resting membrane potential up towards our threshold. And at threshold, then we get an action potential. So the muscle starts to contract. Calcium channels themselves open up even faster. We get even more calcium channels opening up, and that leads to the depolarization of the cell. Then we get repolarization as we move along there, and we come back down towards our resting membrane potential. That is there. The ability to go from one to the next is, again, a relatively slow process. We have a long period of time where we are in that absolute refractory period itself. Our autorhythmic cells are found in two major places. We have the sinoatrial node, or the SA node, and then we have the atrioventricular node, or the AV node. The sinoatrial node is found within the right atrium, so it's kind of up towards the upper posterior aspect of the right atrium, and it's generating an action potential at roughly 75 times a minute. And so this is under the influence of the nervous system, primarily the parasympathetic nervous system, and it's going to keep that rate at about 75 beats per minute. The AV node is going to be slightly inferior to the SA node, and the AV node is kind of at the junction of the wall between the atrium and the ventricles themselves, again in that right atrium. Once the signal gets from the SA node down to the AV node, we have what we call the AV delay. And so this delay there essentially allows for the blood to flow from the atria down into the ventricles before we immediately start contracting. So the pulse coming from the sinoatrial node travels across through the two atria from the right towards the left, and then it makes its way down towards the AV node. And at the AV node, it's then going to travel down through fibers that make its way down through the interventricular septum of the heart. And those fibers are going to be what we call the bundle of His. So this is the atrioventricular bundle, or the bundle of His, and we also have a right bundle branch and we have a left bundle branch. Those two bundle branches run both along that interventricular septum that we have. So it has two ways down through there. So it is a right and a left side towards it. Both bundle branches carry the impulse down towards the apex of the heart. So it's traveling down towards the apex of the heart. And if I just draw my heart here, right in there, and I'm just going to draw the areas there, that electrical signal is moving from the SA node down to the AV node, down through the bundle of His, and when it gets to the apex of the heart, the two branches that came down here split and go up through the two separate ventricles. And so it's going to split at the apex, and we're going to have one move towards the left ventricle, one move towards the right ventricle, and our contraction is going to basically travel along that ventricular wall from that point. So contraction kind of moves down this way, and then it moves back up this way. So we move the blood from the atria down into the ventricles, and then we need to move the blood out of the ventricles, so it's going to squeeze it back up and out of the ventricles themselves. And that's going to be moving along those Purkinje fibers. So here we have a much better drawing than what I can do. We begin here in the SA node. That impulse travels to the left atrium, down through the right atrium to the AV node. That AV node pauses for a moment and then sends its signal down into the interventricular septum. We have a right bundle branch and a left bundle branch, and then down through the apex, it turns back around in a sense and comes back up the walls of the ventricles as the Purkinje fibers. And so that makes its way up from there and travels back up the wall itself. And so we're going to squeeze the blood down towards the apex, and then we're going to squeeze from the apex back up, and our blood's going to head out from there. All of this contraction, all of this sending of signals in the heart, this is what we are able to, in a sense, monitor using an electrocardiogram. And so an ECG or an EKG, as you've heard of it before, is just simply looking at that electrical impulses as they travel through the heart itself. And so we have impulses that begin at the SA node. We see that as the first portion of our rhythm that we see there. And so this is what we're going to see as our P wave. And that's going to be the contraction and depolarization of the atria. We then move, as we come down through the bundle branches down towards the apex, we get into a period of time where that electrical impulse is dropping. And then we get this big change, that big portion that's going to be there. This is going to be our QRS complex. That is related to our depolarization of the ventricles. And so massive, huge process that's going on here. The last little hump here is going to be the T wave. And the T wave is going to be the repolarization of those ventricles. And so that's going to happen after that depolarization has occurred. And here we have a little animation that goes along with the actual EKG itself. And we can see that when we have that P wave, that is occurring during the atria depolarization. The QRS complex is during the depolarization and the contraction of the ventricles. And then our T wave is ventricular relaxation, our repolarization of the ventricles themselves. Slightly different picture, but the same concept goes as well. So we get our SA node firing off, and that's the beginning of our P wave. The atria contracting finishes our P wave, and so that ends the P wave itself. We then have a period of time in between the P wave and our Q, and that QRS complex is going to begin the actual depolarization and contraction of the ventricles. So we see that as our QRS complex there. From there, the ventricles are contracting and they're starting to then relax in between our S and our T there. That's that final contraction of the ventricle itself. And then the T wave is going to be our repolarization of the ventricles. The thing that we don't see on here is this period of time here where the atria in red are repolarizing. That repolarization of the atria is happening at the same time as the QRS complex. So the ventricles are contracting, and basically the QRS complex, the ventricles contracting, is kind of like a bigger event than that of the repolarization of the atria. So we don't see it on this particular type of an EKG that we're doing. So the heart can do all that on its own. It can begin its contraction at the SA node there, send it down to the AV node, to the bundle branches, to the Purkinje fibers, and we get contraction. But the heart doesn't just work all on its own. It doesn't have its own processes that are occurring all by itself without influence from the nervous system. And so we have two different sides to our autonomic nervous system, one of which is our parasympathetic fibers, and the other is our sympathetic fibers. So sympathetics, fight or flight, this is going to be cardioacceleratory. Oops, my Y got kind of cut off there. So cardioacceleratory, this is going to speed up heart rate, increase contraction of the heart. Parasympathetics are rest and digest, so cardioinhibitory. This is going to slow down the heart rate, slow down the contraction of the heart as that's occurring, which means that we're going to have essentially two different processes happening there. Most of the time, we're going to be under the influence of the parasympathetics. And so parasympathetics are going to reduce our heart rate the majority of the time that things are going on there. So in order to see what's going on in the heart, we have these electrocardiograms. We have our ECG. This allows us to look at and determine whether the normal electrical activity through the heart is normal or not. Is a person having a problem with getting those electrical signals to travel through the heart in the proper way? And so again, we have the P wave. This is depolarization of the SA node. The QRS complex is ventricular depolarization. The T wave is our ventricular repolarization. And once again, the atrial repolarization in a sense is missing, and that's because it's overshadowed or masked by the QRS complex. There are ways to be able to look at an ECG and determine and see how the atria are repolarizing. We just have to use a slightly different setup than what we would normally see in the lab, or even what you would see on your, say, like an Apple Watch or something like that, or some sort of other device that is able to measure your electrocardiograph that way, just simply using just a single lead or a 3-lead process that's there. So all of it has a meaning to it in terms of what's going on within the heart itself, and we look at things to determine what may be going on. So we can have situations where we have ST elevation, and so that starts to elevate up. We can have P to Q interval increasing at times. We have that ST segment increasing at times. And that's going to tell us a little bit about what's going on with the person's heart electrical activity itself. If their tracing does not look normal, depending upon the type of issue that is there, we can have atrial fibrillation and ventricular fibrillation and things like that, where the atria and the ventricle are not functioning the way they should. And we'll talk about that next time. Those changes may require a pacemaker. So we also have not just pacemakers, but this one here happens to be an implantable cardioverter. So this is like having a defibrillator implanted in the person's chest. It's not only going to monitor the electrical activity of the heart, but it also has the potential to be able to convert that cardiac rhythm back into a normal sinus rhythm. So the heart, when we look at it diagnostically, we look at things like the ECG, and then we also do things like just simply listen to it. And so when you listen to a person's heart, whether it be with just putting your ear on a chest or using a stethoscope, you're hearing sounds there. And so typically what you're going to hear is a lub-dub. And so that corresponds to the closure of the valves. And so it's not the muscles contracting or the blood moving or anything like that. It's actually those valves slapping shut. And so that corresponds to two different times that this occurs. So our lub sound is actually the AV valves closing. So when we think about it, we have the first process that occurs is atrial contraction, and the blood's going to move down into the ventricles. Once the ventricles are filled with blood, then we're going to get contraction of the ventricles. And so that contraction of the ventricles is going to cause the closure of those AV valves. Once blood then moves out of the pulmonary trunk and the aorta, that blood is going to start to push back towards the pulmonary and aortic valves. This is then going to be seen or heard rather as our dub. And so the second sound is when our semilunar valves close. And so the two sounds themselves go with two different components of the heart contraction itself. We have our systole and we have our diastole. Diastole being the beginning of our relaxation of the heart, and systole being the contraction of the heart itself. Those valves can be heard in different areas, best on the chest, in specific spots on the chest themselves as well. And so the aortic valve, the pulmonary valve, the mitral valve, and the mitral valves can be heard in slightly different areas on the chest itself. And kind of a mnemonic to remember is a pet monkey, as we go through and listen to the different areas of the chest where those sounds can be heard. And we'll continue there the next time.